Yeah, ma'am.
Yeah, okay. So, like we were talking that, in terms when at least COVID has taught us one thing, that oxygen is extremely, extremely vital. Before that, I think a lot of people used to take respiratory problems very easily and be very, very laid back about it. So, I think the most common symptom that would bring the patient to the ER would include breathlessness, followed by cough and wheezing. Now, these emergencies will actually include a wide variety of diseases, like we've discussed. They can range from severe to life-threatening, and hence it is very, very important that we identify and intervene in time. So, the very most common disease that can actually be life-threatening, needs a lot of aggressive management, is ARDS. So, when we talk about ARDS, it is basically acute respiratory distress syndrome, which is rapid onset of non-cardiogenic pulmonary edema resulting in respiratory failure and hypoxemia. Very recently, we have seen a lot of ARDS patients, especially owing to COVID. The incidence of ARDS had massively gone up, especially in the second wave. We have seen a lot of these patients get really sick. A lot of them, made it well. A lot of them, unfortunately, did not. So, one thing that actually scares a pulmonologist or a physician or an intensivist is ARDS. A major hurdle to reducing this ARDS mortality is that the current treatment is limited to preventive measures such as the use of lung protective ventilation. So there is no definitive treatment. So you treat the cause, and other than that, you just provide supportive treatment to the patient. A lot of that involves lung protective ventilation. There are a lot of ongoing studies. There have been in so many years and decades, a lot of studies, a lot of research happening around ARDS. But fortunately or unfortunately, somehow something or the other, just, something comes up, and then another study after some time would come up defying the uh, usage of that particular drug or that particular intervention. So the only thing that so far actually remains definitively useful in the treatment of ARDS is lung protective ventilation. Hence, the management is often challenging, and often also because very often there will be multiple problems in the same patient, which may range from multi-organ failure, also develop non-pulmonary organ injury such as acute kidney injury or liver dysfunction. Apart from, of course, the lung involvement, these patients can also be the ones who can be in fulminant sepsis, have extremely high infection, and a lot of them may even have neurological problems. So, and we have recently seen, I think, a lot of the patients admitted in any hospital across the country were, most of them were COVID, and 30 to 40% of these COVID-19 patients actually developed ARDS, which is extremely high for any illness in a standalone way. And almost 70% of these cases had fatal outcomes. So signs and symptoms suggestive of ARDS, of course, there will be breathlessness, and other than that, everything else will probably be associated with a underlying cause, which could be sepsis. It could be the patient could also be in septic shock, uh, leading to organ hypoperfusion, low blood pressure, altered mental state, low urine output, and increased lactate levels. Any patient with fulminant bilateral pneumonia or unilateral pneumonia, which is severe, can also land up in ARDS. Patients with trauma, patients with inhalation injury, patients with poisoning, patients with viral infections, drug toxicity, and sometimes even transfusion related acute lung injury can happen and lead to ARDS. So talking about management, like we have discussed, that it's majorly supportive. So there are general measures which include nutritional support, prevention of stress ulcers and venous thromboembolism, prevention of bed sores. Of course, the ventilatory parameters need to be closely watched. The mental status needs to be closely watched. Sometimes on the ventilator, you keep these patients on some sedative or maybe on awake sedation, and you have to repeatedly reassess, give them sedation breaks, and reassess their mental status as well. So, ventilatory parameters are the most important part of management of ARDS. It basically forms the backbone of ARDS management, and the ventilatory parameters are very fixed when it comes to ARDS management, and they are very universally followed. So you choose any mode, maybe, like a volume assist mode. Keep the inspiratory to expiratory ratio of 1:1 to 1:3, depending upon how the ABG is for the patient or particular patient. So if the CO2 is high, you keep a high expiratory ratio. You keep a higher PEEP, higher than 5 centimeter of water, and almost around 12 millimeter is actually the preferred one, but you basically titrate it to maintain an FiO2 of less than around 200, but also at the same time, make sure that there is not a lot of auto PEEP generated. Keep the respiratory rate below 35 breaths per minute. And the backbone, the basic formula still remains that keep a low tidal volume. So tidal volume of an average of 6 ml per kg is what you target. And depending on that, you do the settings for the ventilator. So you never actually, it's not necessary that you target the arterial pH bang at 7.35. Sometimes in certain patients, you may even have to accept a slightly lower arterial pH, something like 7.30. Sometimes just accept a little bit of hypercarbia, which we call permissive hypercarbia in these patients. So you may just permit a little bit higher PCO2. You're not targeting a normal PCO2 if everything else is right in place. The basic parameters that you have to monitor constantly is target saturation of 88 to 95%, a PaO2 of 55 to 80, keep a plateau pressure of less than 30. That's so these are things that you're basically going to target, and also make sure that the patient is not oliguric, is very well perfused. So these are basic things that you will keep in mind when you're managing a patient of ARDS. Along with all of it, you have to at the same time make sure that you do not go overzealous with the fluid therapy. So there you just actually stick to conservative fluid therapy, neuromuscular blockade for early severe ARDS, and then eventually, of course, you can, titrate the patient to awake conscious sedation as well. Prone positioning is very helpful. Prone, we have, during COVID seen that prone ventilation has its own advantages. We have even actually been proning conscious patients who have not been ventilated, but when it comes to ARDS, even ventilated patients are prone, and it is extremely helpful for their ventilation perfusion mismatch. Of course, as the patient improves, we do give them spontaneous breathing trials and follow the weaning protocols. The use of corticosteroids, like I said, is controversial. There were initial studies which said that it was helpful. Then there came certain studies which said it was not helpful. In fact, it was counterproductive. But then there were again some studies which said it was helpful, especially in patients who were in septic shock. So it is a personal choice. You have to be extremely careful where you use it and whom you use it and how much you use it. Now, there is this other thing that I'm sure all of you have heard of, which is called the ECMO. It is an advanced strategy for people who are not doing well on ventilators, who do not have multi-organ dysfunction, who do not have bleeding diathesis. So for those patients, you can actually even consider ECMO. It helps. There have been certain studies done on inhaled nitric oxide. Also, there are these recruiting maneuvers which have been extremely helpful when you're managing a patient of ARDS, whatever the cause. We've talked about various trials, and I think the gist remains that, of course, there are a lot of trials happening, and we will probably in a few years have a better understanding of management of